So now I'm going to welcome Linda O'Connor to chair our final panel discussion. So this one is on maternity care. Linda herself is Head of Maternity and Gynaecology Policy at the Department of Health, and there she leads on driving the implementation of the National Maternity Strategy, which expires next year, and she also has oversight and governance of the maternity and gynaecology policy in acute hospitals. So Linda, I'm going to hand it over to you.
Good afternoon, everybody, and thank you so much for welcoming here today. It seems fairly normal that following a discussion on reproductive rights that we would move on to maternity care, and that there may be consequences. So, as was told, I have responsibility for the implementation or oversight of the implementation of the National Maternity Strategy 2016 to 2026, which is entering its final year. The government, under the Programme for Government, has committed to a successor to this strategy. Now, a lot has been done under the strategy, but obviously there's a lot more to do. So, moving along, as we're told, we don't want to delay too much. It's my role here today to introduce you to the panel. The first speaker we have is Dr. Deirdre Daly. Deirdre has conducted, obviously she's Professor of Midwifery and Nursing at Trinity College. She has conducted research for the department, but also what she'll focus on today is research that Deirdre has conducted on deaf women's experiencing in navigating maternity services in Ireland.
Thank you very much. Afternoon, everybody, and thank you so much for staying, although it has been an exciting day and a great conference. We've got about 10 minutes to talk, and I'm going to talk for about 9, but I'm not going to talk for 9. I want you to hear what we learned from women who are deaf and who use the maternity services in Ireland in the last couple of years. So this presentation is brief, but it's a little bit about background to the research, why we did it, what we know already, but primarily focused on what did we learn from the women. We have a lot of really, really great information on women's health during pregnancy and during labour and birth in Ireland. But I went to find out how many women who are deaf or hard of hearing or use translators in the maternity service, and there are no data on them. But we estimated based on the numbers of women that were attending one large hospital, and we estimate, and it's conservative, about 300 women per year. Older studies on the maternity and women's experiences would show that deaf women experience difficulties with both the method and quality of communication and health education, crucial to their experience of maternity services. Didn't feel respected or that their health needs were recognised. And all of these experiences were limited by access to interpretation services. Since then, we have the legislation, and we also have the HSE's lovely document on speaking terms, which offers advice to us on how we should be interacting. So this project, conducted last year, aimed to understand women's experiences of the maternity services. Following ethical approval and data protection officer approval, we approached deaf women's societies and deaf communities and asked them to share the information, which they did, thankfully. And we wanted to recruit deaf women aged 18 years and over who had given birth since 2018. We recruited 15 women in the space of 2 weeks, I think it was. And we interviewed them between January and March 2014. All of the interviews were conducted in Irish Sign Language by a woman who is herself deaf. The interviews lasted anything from just under 40 minutes to well over an hour, and there were audio and video recorded and transcribed and then thematically analysed. The findings today, I'm not presenting under the themes, I'm presenting along the continuum of pregnancy, labour, birth, postnatal care in hospital, postnatal care in the home. So you see the flavour of what it's like for a woman going through that service. So what was pregnancy care like for Emily? Lots of women repeated all of these themes, but what a lot of women spoke about was this relationship. And women who are not deaf and who are hearing talk about this as well, and it's the continuity of carer. The continuity that enables you to build a relationship so that trust becomes established between you. Deaf women talked about trying to buy this continuity of carer by attending a consultant privately. Very expensive. As Emily said, they were told that they were responsible for booking the interpreter. And women talked about this choice between, do I go for group antenatal classes or one-to-one? And what they really talked about was them getting the choice for themselves. There's something I'm going to come back on that's here, and it's the continuity of interpreter too. I have it on there, but I'm going to mention it at the very end. Paula talked about her labour and birth experience. Some of this is hard to hear and comprehend, but there was also other instances women talked about clinical incidents happening and the interpreter either going with the baby or being with the baby or being with the partner, which left the woman alone. And this was one woman's experience during a cesarean section when her arms were spread out and she couldn't sign. And the interpreter was standing behind her, so she had no means of communication at all. Same happened to another woman when the baby didn't cry. Oh, the baby didn't cry and her partner, the interpreter went with the partner. So they raised the really key issue of when do you need two interpreters? One woman talked about labour and birth at home, and she chose a home birth and paid for a home birth midwife deliberately so that she could again get this continuity of carer. She could take control, make all her own decisions, and describe this experience as the best. All of the women talked about the absence of postnatal or interpreter service during the postnatal period in hospital after the birth. And they talked about not understanding why this was happening, wanting to ask a lot of questions about their health, and questions that keep them safe, and being able to do so. They talked about not having treatments explained or even been asked for consent for things like a baby's injections. Some of them gave lovely examples of being offered a baby alarm, one of these that will go off, but the challenge of having that and being in an open ward with a lot of other women where you'd sit up all night and wouldn't sleep because you didn't want to disturb others. Mary talked about breastfeeding. There were other issues, and particularly for things like special care or special circumstances, where there are intercoms on some of the systems in maternity hospital, but that's prohibitive for a deaf woman. And having to wait for someone to let them in, really powerful words. And even when this woman got into maternity service, neonatal intensive care, her baby had been moved, but she hadn't been told. And the fright that she got still lived with her. And that was a word that women talked about a lot, the stress that they experienced. They also talked about the continuity of care from community midwife again. But across the whole finding, they talked about these two continuity of interpreter to build up the relationship. Women used these words quite a lot when they talked about the services. Uninformed, distressed, worried, exhausted, frustrated, lost. They lost trust in some maternity professionals. All of this means that their rights are breached, but their health is at risk. That's what we learned from women for this study. We also learned that we should integrate Irish Sign Language into other resources that we developed so women can learn information that will help themselves. And we have a bit of work to do with dissemination. We're producing lovely videos with tips and tricks for services. Thank you. And thank you to the women.
Thank you, Deirdre. That was difficult, some parts of it to hear, but certainly women's experiences are central to what we look at for the next stage of the strategy. Our next speaker is Karen Henry. Karen is a midwife and a lecturer at the University of Suffolk. Karen has worked with women who's supporting autistic women in accessing maternity services and other good practices to support pregnant autistic women. Thank you, Karen.
Thank you. As we know, autism is a neurological difference in the way that individuals perceive the world around them, and this can cause sensory processing of environments and communication styles to be different. And also they might have challenges around executive function. And it's often noted that 3% of the population are autistic, but actually this figure is much higher. And in NHS training for midwives, autism is usually clubbed together with learning disabilities, and whilst autism isn't a learning disability or a learning difficulty, it can co-occur with one, but that the training packages that are available in NHS trusts lead to this presumption that autistic women have a learning disability, and there's this perceived inference about their abilities. But actually autistic people have this spiky profile where they have everyone's individual, and some people can have challenges in one area and abilities in others. Many autistic people are highly successful, they have successful careers, but actually it's interactions with the environment that cause disability. So accessing maternity care for the first time can be challenging for some women. So there are challenges for girls and women in relation to assessment and diagnosis, and this is because early research was conducted in the 1940s by old white men who studied young white boys and discovered autism, and up until 2018 this was the criteria used to assess people for autism. And it failed to acknowledge that girls present differently, and girls actually they learn to copy and mimic behaviours from quite early on. They learn to have eye contact with people, and they learn social scripts for communicating. But actually, this processing of masking for women is really exhausting, and it takes a toll on the body. And it's for this reason that many women remain undiagnosed as children, or they're misdiagnosed with mental health conditions. And actually so many women will enter maternity care undiagnosed, which means that this will cause them more challenges. And currently the waiting time for assessment in the UK for adults is 6 years. I just want to talk a little bit about the toll that masking can take on the body, and then I'm going to move on to maternity care. But the toll of masking on the body can be referred to as weathering, which is a term coined by Arlene Geronimus to explain how living with extraordinary stress damages the body at a cellular level, and it can cause chronic health conditions and premature death. So even before accessing maternity care, autistic women may have experienced ill health and trauma, which will actually impact on their pregnancy, their perinatal journey, and the future health of their baby. And autistic people can spend many hours in chronic stress states through being vulnerable to bullying, sexual assault, exploitation, unemployment, barriers to healthcare. There may be co-occurring health conditions too. And in the general population, 1 in 4 people experience poor mental health. But when autism is a factor, this is more than double. So there was a study in 2014 of 374 autistic adults, and 66% of them had contemplated ending their own life, with 35% actually attempting to do so. And in the general population, men are more likely to end their life. But when autism is a factor, this is flipped on its head, and it's actually women who are more likely to do so. So when you consider the perinatal journey, which actually might exacerbate poor mental health, and that suicide is the leading cause of maternal death, this is why supporting autistic women is important as well. And encountering such traumas on a regular basis causes that weathering of the body. And autistic women have a life expectancy of up to 16 years less than non-autistic women. And for people with a learning disability, their life expectancy is half that of non-autistic people. So it's important that maternity care doesn't add to this weathering, but the experience is no better. So postnatal wards are described as hell on earth, as women feel overwhelmed by the sensory overload from smells, noise, lights, disruption, and the sheer amount of people. And it's actually in these disabled environments that women can't process information, that they struggle to function, and yet this is the very environment where women's parenting capacity is assessed. So in the UK, questioning about autism is not actually included in the booking appointment. So midwives rely on women to tell them, that they're autistic. But women actually fear being judged by maternity staff, and 40% of women actually don't share they're autistic. But actually, the women that do share it, they're not offered support either. So really, we don't ask because there's no support offered to them. So what's the point in asking? But really, we should be asking. And women don't share they're autistic because they worry about having their parenting ability judged. And this fear is warranted because midwives will refer women to social services because of the assumption that autistic people lack empathy and so can't be good mothers, when actually there's a lot of evidence to the contrary. So when we put all this together, it shows that autistic people or autistic women need individualised support. I'm just going to have a drink. I'm talking too fast. But actually, it's not just the women who feel out of their depth, it's the midwives as well. And NHS training is very basic. It's based on that male model of autism. It's actually grouped together with learning disabilities. So the training's just meaningless. It's actually not even relatable to maternity care. And in the UK, the NHS has implemented the Oliver McGowan training, but that is not relatable to maternity experience at all. So midwives feel fearful of saying or doing the wrong thing, so they often say or do nothing. And even midwives who've supported women before feel out of their depth with this huge responsibility to refer autistic women to social care just to cover themselves in case down the line that woman can't look after their baby. And when I conducted my own research, I found that midwives who have personal autism experience possess knowledge that is not included in any of the books or training packages. So education needs to improve. And I'm going to slightly skip over some of these reasonable adjustments because I want to talk about an initiative that was implemented. But we need to implement adjustments. We need to have reasonable adjustments to make care accessible, and continuity of carer is essential to build those trusting relationships. Care should be provided by midwives who understand autism. Sensory processing needs to be supported by allowing extra time for appointments and allowing women to be accompanied or to have their appointments recorded on their phones, and consider, allowing women's advocates to ring the delivery suite for them and not insist on speaking to the autistic woman. We also need to consider how women access their appointments and the environments that they access their appointments in. So we need to consider providing, virtual tours of maternity units and, maybe women having their appointments with the same midwife, and consider, how the woman will experience the environment. And I'm going to skip on a little bit. So it's really important that women have individualised care. And when I was a student, a midwife, I supported an autistic woman on the ward, and I recognised that actually she was unprepared for the hospital environment, and actually the midwives were unprepared to care for her because they were quite reluctant to care for her because they didn't know what her needs were. So I developed a series of support plans which were adapted, they were built on in 2020, and they were implemented into practice, but because midwives don't ask women at booking if they're autistic, they were rolled out in the perinatal mental health team. So the support plans were used for women who had poor mental health, who were also autistic, and for women who were under the vulnerable women's team, so they already had social care involved, but they were also autistic, and the women found the plans really useful. The midwives in those teams had training, and felt that they opened up dialogues with women about what adjustments they might need making in the maternity environment. But when the women then went into hospital, because training hadn't been implemented across the unit, the midwives didn't know what the plans were, and so they weren't used, or they were, I haven't got time to read that. So this implementing these plans highlighted that there's a big population of autistic women who are not even being supported at all, and that you're only picked up by mistake if you're accessing another team. So I've actually developed a digital version of these plans, and with a resource pack for midwives to go alongside, and that's being funded by the National Autistic Society, but really it's not enough either. And trust guidelines are not maternity specific. They usually use the generic trust learning disability and autism guideline, and then just try and make it fit for maternity. But research is growing in this area. So I'm one of the founding members of the Maternity Autism Research Group, and we're a collective of autistic researchers and midwives. We're trying to advance research in this area and advocate for autistic women. And I'll just tell you about one project. There's a project by Swansea University called the Autism from Menstruation to Menopause project, and they've developed over 130 videos for autistic women and parents to support them navigating the maternity system and maternity care. And there's a lot of resources for parents who are made by parents who are autistic themselves. And so I think the message really is that yes, these support plans are useful, but midwives need to understand why adjustments are needed, and they need to understand autistic people's experiences. And so training needs to be led by autistic people and not directly from NHS trusts. And I'll end there. So thank you.
Thank you, Karen. Thank you for that. Next, we're going to hear from Dr. Carly Cheevers. Carly is a senior research officer here with the National Disability Authority. She has conducted research on experience of women with disabilities on their journey through the maternity services in Ireland. This would have been based on the 2020 National Maternity Experience Survey, which has just been repeated this year and just complete. Yeah. Thank you, Carly.
That was my punchline. Okay, thank you so much. So yeah, I'm going to present on work that was done in the NDA in 2021 based on data actually from 2019. So we conducted secondary data analysis of the National Maternity Experience Survey, and we received the data from HICWA. So this survey is part of the National Care Experience Programme, and that's an initiative by HICWA, the HSE, and the Department of Health, and it's asking people about their experiences through healthcare and using that feedback from users in order to help improve health and social care services. So the aim of our piece of work was to describe the experiences of women with long-term disabilities accessing maternity services in Ireland and compare their experiences to those without a disability. And the purpose of this was to get policy and practice relevant research findings on service and support needs of women with disabilities in maternity services. It also fulfilled a responsibility that we had in the NDA to undertake research to guide maternity services and supports for women with disabilities during and post-pregnancy, which was an action in the National Strategy for Women and Girls 2017-2020. We published this report in May 2021. I suppose I was worried before this that some of the findings might be outdated, but I think as we've gone through the day, they definitely aren't, they're still very real today. In terms of the participants of the survey, The target sample were mothers aged 16 and over, living in Ireland, and who gave birth October to November 2019. 3,204 respondents took place or agreed to take part, and that was about a 50% response rate. 217 women reported that they had long-term illnesses, disabilities, or conditions, so that was 6.8% of the entire sample, and almost 9 in 10 of these reported one disability. In terms of the type of disability, you can see there that almost 60% reported a mental health, psychological, or emotional condition, and just over a quarter had another disability or chronic illness. Under 5% had other conditions, and just looking at Deirdre's research, there was obviously a massive underrepresentation of women who are deaf or hard of hearing in the sample. So I'll go through the limitations of using this sample in a bit, but just to go through what the survey is like. It takes women through their entire maternity journey, from antenatal care through labour and birth, their experience in hospital after birth, if they end up in specialised care, what their experience was like in the neonatal unit, their care that they got for feeding, and the care they got in the home after birth. The general types of questions were all about their experiences with regard to choice, respect and dignity, communication, information provision, decision making, relationship with professionals, and then just some questions specific to the stages. So I wanted to preempt some of your criticisms and go through what the caveats and limitations are for this piece of work. Obviously, treating a heterogeneous group of women who have a wide range of disabilities, illnesses and conditions, treating them all as one group isn't ideal. It doesn't respect the diversity of the group, and also some of the people who took part might not consider themselves as having a disability, but we needed to do a piece of work, and these are probably a group of women who are most in need of women-centred care, which is kind of the fundamental element of the National Maternity Strategy. Also having a large proportion of the sample with mental health, psychological and emotional conditions, there was a worry that their experiences might overshadow the experiences of the other women with other conditions, but I compared their experiences across 49 of the measures, and there was only one significant difference, so we agreed that it was reasonable enough to put these women into one cohort just to get our findings. We also are not sure about the accessibility of the survey at the time. This was 2019. Hopefully things have improved since then. The representativeness of our sample in terms of women with disabilities. And then just generally, it was a general survey on experiences. It wasn't targeted towards women with disabilities, so it's obviously missing some of the key elements of their experiences or their support needs, for example, accessibility. I'm going to go through some of the key findings, and I'm just going to present on ones that are statistically significant in terms of where women with disabilities, their experience significantly differed from women without disabilities. And when I say statistical significance, it means that we can be fairly confident that the differences are real differences and not random differences. There's also a lot in the report. My colleagues have asked me to condense a 140-page report into 10 minutes, so I'm missing the elements where women with and without disabilities had similar negative experiences. So that is, I suppose, an important part of this, but it's not what we're going through today. We're just going through the differences. So in terms of the overall experience from the report, women with disabilities generally did have positive care experiences. There was a huge amount of similarities between those with and without disabilities in terms of each stage of their journey. The most and least positive experiences tended to be the same. And where there were differences, the experiences of those with disabilities were still, for the most part, quite positive, but just not as positive as those without disabilities. Okay, so in terms of choice, women were asked about whether they were given a choice of maternity care and whether they were offered antenatal classes. And there was slight but statistically significant differences in that those with disabilities reported not being offered a choice of care, and that's not including those who couldn't have a choice of care due to medical conditions, and also there was a higher proportion who reported not being offered antenatal classes. So there's a lot in this slide. So this is kind of the key significant differences between women with and without disabilities across the entire journey. Just to note, there were no significant differences in their experiences of specialised care in the neonatal unit or for their care for feeding. I'm going to start with antenatal, and you can see that women with disabilities felt less likely to have been treated with respect and dignity in the antenatal setting, but they also, in hospital after birth, they also felt less likely to be treated with respect and dignity. They had less confidence and trust in their carers in the antenatal setting. They felt that their questions weren't answered in an understandable way, both antenatally and if you look across during labour and birth and in the hospital after birth. Antenatally, they didn't feel as involved in decisions, and this also came up in hospital after birth and also in their care at home after birth. They also, though, in labour and birth, they didn't feel that their partner or companion was as involved in their care during labour and birth as much as they wanted, which is kind of along the same lines of not being as involved in decisions about their own care. And antenatally, they also weren't given, they didn't feel they were given enough information on physical changes to their body. They didn't get information in hospital after birth about physical recovery and information on whether they were worried after discharge. So you can see there's clear patterns across each of these stages. In terms of the care at home, just to note that there was a lot of the questions were about GP and practice nurse visits and public health nurse visits, and that's where people with disabilities and the women without disabilities, that there weren't any real differences. So that kind of says something that a lot of the issues tended to be from the antenatal and in the maternity settings themselves rather than in the community. Another finding that came up in labour and birth was that women with disabilities were less likely to get skin-to-skin contact with their babies shortly after birth. So I did a bit more on this, trying to understand why that would be. So I controlled the analysis for whether they had had different types of births, whether they had a complicated birth, and nothing was coming up. But then when I controlled for the type of feeding, this relationship disappeared. So it suggested that those women with disabilities who were not breastfeeding were not given opportunity to have skin-to-skin contact. Anyway, I see the light is flashing at me already, so you can ask me about that later. Basically, then we sent recommendations to everyone involved in the National Maternity Experience Survey. We reminded all these organisations of their statutory duties. We basically, communication and information provision and relationships underpinned all of these issues that were coming up. We advised everyone to use, there were existing resources created by the HSE and the NDA and government resources, to use these in order to improve their information resources. Obviously, that there should be better awareness and disability competence training for everyone across the maternity pathway. We encouraged universal design approach for maternity hospitals and units. We reminded HICWA and the National Women and Infants Health Programme to consider those of sensory disabilities when they were talking about accessibility. We recommended, or we said that every woman should get, oh no, I've got time up. I've got 15 seconds on the clock. Basically, then we also advised HICWA to ensure that women with disabilities could participate in the survey. And one of the good things about this experience survey is that the HSE and CHOs and the maternity services, they all have to do quality improvement plans. But our message to them was, well, you need to, if you're not going, they hadn't analysed disability, so if you're going to do these quality improvement plans, you need to disability proof them so that you're not exacerbating or perpetuating these differences. So the recurring differences were choice, control, communication, information provision, and yes, the survey for 2025 has been done. The report is due in December. There's more with long-term illnesses in this sample, but the same overrepresentation of those with mental health issues. But I have been told there is a limited analysis of disability in the main report, so we need to look, again, take a detailed look and see what has changed since 2020. Thank you.
Thank you. Thank you, Carly. So our final speaker on this panel is Dr. Alison Harnett. Alison is CEO of the National Federation of Voluntary Service Providers. And Alison has looked at the importance of healthcare professionals who provide maternity services, informing families that a child has a disability, particularly during pregnancy or at birth, in a supportive way and in line with the national best practices for informing families of their child's disability. Thank you, Alison.
Thanks a million. So I'm really grateful that you're still here, and I'll try and be brief. So Carly, you've spoken about a long period of data gathering, and I suppose I'm going to be speaking about a programme of work that really has been taking place almost over 20 years. So forgive me if some of the data is a little old, but I think some of the concepts hopefully remain. We do know that family is the principal context for development for any of us. When we think about where we first learn to think, be with people, talk, for those of us who are using language, to speak, to all of the developmental things that happen for us in our family. So in a way, the moment of birth is the first opportunity we have to celebrate disability, to have a positive attitude, and to begin to think about an empowering approach to disability. And so if our support for disabled people is going to be there at all stages of life, we really must think about this important moment of the time that we inform a family that their child has a disability, whether that's a disabled parent or a parent without a disability. And we do know that family and community are completely interconnected, and Dunstan Trevette have described family as a social unit embedded within other informal and formal social networks. And I suppose within an ecological environment, family is influenced by attitudes out in the society, and society is influenced by what happens in the family. So I think what we do in the single moment of a maternity also affects many things across the life cycle. So the research began actually 18 years ago and has continued in different parts of programming over the years. Families have told us that the moment of hearing of their child's disability are words that they will never forget, that have an impact on their levels of distress and anxiety, a bearing on the attachment process, and can influence the parent-professional relationship thereafter. So if the moment in which you are given the information that your child has a disability is conducted well and supportive, that might help you have influence good parent-professional relationships on the start of that road. And conversely, if it's a very negative communication, that's not a good start for a parent-professional relationship. And we do know that people will have professionals in their lives by virtue of the fact that there may be additional needs. For professionals as well, similar to other studies, we've heard that professionals find it very emotionally and challenging experience to be in the maternity ward or in the antenatal experience, discovering that a child has a disability and knowing that they need to communicate this with the family. And they have said that this is something that requires training and support and clear guidance. And that's why we developed the Informing Families Best Practice Guidelines. To give a brief overview of how we did that, we did a comprehensive literature review. We undertook 21 focus groups with parents and with professional disciplines. And interestingly enough, we found 33 different professional disciplines who are involved in informing families of their child's disability in different scenarios, whether that's a paediatrician, an obstetrician, sonographer, many different midwives, many different professions who may be involved. We did a questionnaire survey of 584 parents and 1,588 professionals, and that led to the release of the report, guidelines, and a DVD of family lived experience. We launched the guidelines and then began implementing them in the Cork region across hospital, community and disability services. And that project really brought together a lot of different experiences across family, and it was chaired by a family of 2 children, one with a physical disability, one with an intellectual disability, and it really helped gel together and provide that lived experience. The HSE and professional bodies then really supported national rollout, both online and in-person training, and I suppose a lot of that was going on until COVID took place and my own role changed and I became the CEO of the organisation. So more recently we've begun revisiting the concepts that have been there, and I think it's probably timely as staff turnover happens that we probably need to relook at training in those pieces. But families have experienced, unfortunately, blunt and insensitive communication, they've told us, in environments that haven't always been private. And I think the one message I'd love to leave people with today is that parents have told us really clearly that they don't want only negative messages about disability at the time of a diagnosis. It is absolutely correct that we need to give accurate information, truthful information. But while 84.5% of the parents in our study found that the professional giving the news was direct and honest, less than half of them felt that they'd been given the news with any hope or positive messages. And parents then referred to being given a range of the worst possible they would like to be given a range of all of the possible outcomes rather than merely the worst case scenario. And I think the best way that I could communicate this was a father from the study who said, if you have an ordinary child, they're not going to give you a book saying he's going to rob a car and fail all his exams, get a girl pregnant. But for some reason, when you have a child with a disability, people think we have to tell you everything that could possibly go wrong for that child. And they don't do that when you have a child without a disability. So parents were really saying, please allow us to celebrate the birth of our child. So parents at that time were telling us that 36%, 0.4% were satisfied with how they'd been given the news. Unfortunately, more than 66% of the professionals were satisfied with how they'd given the news. So I guess our guidelines were aimed at closing that gap a little bit so that we could help. So we were trying to close that gap, and one of the things that we have discovered really is that diagnosis and disclosure is a process. It's not a one-off event. People need to hear the news, possibly gradually, possibly having other appointments to confirm what they've heard, and it can involve staff members from acute, community, disability service settings. Parents need information. In our study, a lot of parents didn't understand what they had been told or hadn't been given written information. And a lot of parents were told at the end of a bed without privacy. So it's really important to take into account the individual nature of the family. The disability, are the parents experience disability themselves? Are there language, cultural, family makeup needs? Is there a need for accessible information? Is the person in a geographic location whereby it would make sense? One of the really simple things that came from the study was, if you have a parent and you know that you're going to be giving them difficult news in an antenatal or a postnatal appointment, make it the last appointment of the day so that they can have time at the end to come out, not into a full waiting room as they kind of come to terms with the news, but be able to have that little bit of time just to gather their thoughts. And also from a geographical point of view, that they may not have to stay overnight for that first appointment. So there was lots of things that we found, and I suppose the need for continuity of care and a named liaison person echoes what the findings from many of the other studies we've heard there this afternoon. And I suppose the implication is that there is going to be a need for teamwork at the individual practitioner level, at local level, at RHA level and nationally, and that includes where hospitals in the regions might need to refer up to the national level. So there's a lot of things to be considered as we look at the new regional structures. The guiding principles are that every diagnosis should be child and family centred, demonstrate respect for the child and family, and in this conference, as we're speaking about it, particularly the child and family that a child is born into when they have a disability and their family has a disability is something that we've obviously heard a lot about, taken into account today, with sensitive and empathetic communication, appropriate, accurate information, positive, realistic messages with hope, a team approach and planning, and focused and supported implementation of best practice. And I know we're just touching on the concepts here. I'm more than happy to speak in further detail with people who have an interest in this area. The physical and social setting and the recommendations of the guidelines fall into a series of kind of practical areas, such as where does it happen and who's in the room. what kind of communication skills that the professionals giving the news might need, the kinds of information and support that should be delivered, making sure that culture and language is taken into account, and planning and organising ahead of time. And that requires training, education and support for professionals, and we have a suite of materials that we're very happy to share to help with that. It has been spoken about as a crisis of information, as parents take into account what is the meaning of the diagnosis, what does it mean for their caregiving and the future. But it is very clear from parents who've been involved for longer after the diagnosis that there's a joy and a sadness coexisting, and that people do come to terms and begin to celebrate their child and understand that their child is so much more than a diagnosis of disability, which may not be apparent at that time of the diagnosis. So parents have started stepping into this space and congratulating other parents as their child is born, and providing, you know, gifts, because unfortunately in our research many parents were not congratulated at the time of their child's birth, which is really a tragedy. So parents are stepping in, and I love the picture on the left, and it's Jason Neen saying, what should I expect if my child has Down syndrome? And he says this, 100% this. So I'll leave you with that thought and just return to the start, which is family is the principal context in which human development takes place. So we have a real opportunity to support families in how we provide the news that their child has a disability, and make that the first positive moment of celebrating the diversity of disability, rather than all of the negative things that might happen in the future. Thank you.
Thank you, Alison, and thanks you to all of the speakers here today. I think there's a few signs around that's telling us we're all running out of power. The pad I've been given is flashing, telling me there's 5% less. So if anyone could tell me how long we get out of 5% of the battery, that's how much time you have for questions. So using our 5%, is there any questions for the panel from our audience? If not, I can get us warmed up while it's still working with an online question. Yeah, okay.
Hi, thanks for your presentations. And I suppose just from Alison's perspective and the research that was conducted, how can we work to make things better and, you know, work to implement a really strong plan from the moment, you know, the child is born, to make it a celebration rather than a challenge for people? Because we know that that impacts. People have talked over the last few days, you know, being on the train, you know, suddenly you're on a different train than you thought you were going to be on. And how do we try and alleviate that?
I think one of the important things is training, and we've developed and implemented training after which staff have told us that they really do understand, particularly if it's parent and disabled-led training, where people are saying, please don't be giving these kind of negative messages, because I celebrate my child, I love my child, but I didn't know when you were giving me that initial message how much that would be the case. So I think parent-led training and awareness, and also after doing the training, I suppose go back to that first slide, professionals were asking for the training as well. They weren't sure what to do. They were trying to do the right thing by giving all the possible things that could go wrong, because they thought that was honest. So it was almost empowering people to say it's okay to celebrate this child. So I think making the training part of our structures is really important, so that it's not happening on an ad hoc basis. And I think that will also, when we celebrate people with disabilities, and that goes back to the piece we were talking about, this nested systems, we need to be changing the attitude in every way that we can, so that we're celebrating disabled people rather than worrying about what that means for their lives all of the time. So I know that's a bit of a vague answer, Rosie, but I think we need to structure our training and make it as embedded and into our induction processes as we can. Thanks.
Okay. Thank you. I'll just go now to one of our online questions, and it's saying, what steps can be taken to increase the number of disabled men and women who work as midwives and maternity professionals?
I can answer that. I think we need to, so there's a piece of work that's being done by the Royal College of Midwives to make even applying for university to be a midwife more accessible, because if the interview and interview process and the curriculum, and if it's led by students, then we can filter into practice about making practice more accessible as well. So I think we need to keep going and trying to make midwifery education as open as possible and as accessible as possible, so then we can then work on the practice areas and then try and retain staff.
Okay, have we any other questions from the floor? Okay, one more question then from online. Family with no previous experience of disability likely have never had access to a human rights approach. Has any thought been given to putting families in touch with their local disabled persons organisations for support? Additionally, where a baby is intersex, are the new parents being given support to contact Intersex Ireland to help with perspective and balance?
I can talk to that a little bit. I suppose one of the things that we mentioned in the brief mention about the areas is information and guidance. So families really need access to a wide range of information. In some studies that we did more recently, we were finding, just even in that time where families have received their diagnosis, they may be in the postnatal scenario. Families were saying it's 4 o'clock in the morning that I get a chance to read. So we need access online, and we need access in other ways through the GP or other things. So I think a revisiting of a comprehensive information resource that's available at the time of diagnosis is something that's really needed. And we began that work maybe pre-COVID, and it would be useful to take it back up again. So some of that work was done. And in fact, one of the key areas that we discovered was that we needed to translate all of those materials into all of the kind of key languages that are spoken here, because not everybody's going to be an English speaker. It's really important that we're thinking about the different reading levels, languages, and the different DPO people that they might want to get in touch with, as well as the different diagnosis-specific areas. I think it's important.
Okay, thank you, and thank you to all of the speakers on the panel. Was there something you wanted to say, Deirdre?
No.
Thank you to all of the speakers on the panel today, and thank you for having me. I know from a policy perspective, I've certainly heard a lot here that I'll be taking away. We are doing a lot of good work, and some of it's been reflected back. So again, thank you very much to all of you for having me here, and thank you for the day. I think we'll have somebody now to wrap up.